Give me a second.
Okay.
Start, ma'am. You can start, ma'am.
Right. So good afternoon, respected chief guest, our guest speakers, our own IMA members, chairpersons, president, secretary. This being October, we all must be very busy addressing awareness concerns of breast cancer patients and conducting many such programs. But breast cancer is such a subject which is evolving every day. There are so many recent advances in terms of surgical techniques, technology, as well as not only in the surgical field, but in medical oncology and radiation oncology as well. So every time we listen to a webinar, we always learn something new. So I think it is very important and a very good initiative with IMA Nagpur and Association of Surgeons of Nagpur. It's a combined venture to conduct this CME on breast cancer in the month of October. I would invite Dr. Sanjay Devtare, President of IMA Nagpur, to welcome the gathering.
Thank you very much, Prachi Madam. Am I audible?
Yes, sir. Yes.
Yeah. Respected Chief Guest, Dr. Shivkumar Uttre, sir, President, Maharashtra Medical Council, renowned surgeon, and our star for today, highly qualified speakers, chairpersons, our co-host, Association of Surgeons, Dr. Sudhir Deshmukh sir and Dr. Chavan, MMC Observer, Dr. Ashish Disawal, highly learned audience. Today's moderator, Dr. Prachi Mahajan Madam, has taken a lot of pain in coordinating this CME. Thank you very much, Madam. On behalf of IMA, I thank you for this. Breast cancer, leading cause of cancer in female, and removing of the breast causes double mental trauma to the female. That is one, cancer and removal of the breast. As the days are passing, more and more advances and the researches are coming up so as to conserve the breast as far as possible, so as to decrease mental trauma and improve the survival. Let's add to our knowledge back regarding the same with a highly learned, qualified speakers. And I thank the speaker for their valuable time in the Saturday afternoon. So let's begin with the chief guest. Thank you very much. Over to you, Prachi Madam.
It is our proud privilege. Yeah, it is our proud privilege to have a distinguished chief guest for today's function, Dr. Shivkumar Uttre, who's president of Maharashtra Medical Council, Mumbai, and member of National Medical Commission, and a renowned surgeon. So I would request our president, Dr. Shivkumar Uttre, to address the occasion.
Yeah, thank you, Dr. Prachi Madam. And I think at the outside, I must thank the organizers of today's this CME, because today my two associations which are very, very close to my heart, both the IMA, that is Indian Medical Association, and of course the Surgeons Association, which is, one is my, you can say, Janma Bhumi, the other is my Karma Bhumi. So on behalf of both of them, today I am here. So I am part and parcel of you. I don't think anything chief guest or whatever renowned or whatever words Prachi Madam has used. I don't know how far I justify that, but then it is always a pleasure to be there whenever Nagpur invites me for any program. So President Dr. Sanjay Devtare and Secretary Dr. Ghati, Sachin, and of course Dr. Deshmukh and Dr. Chavan from the Surgeons Association of Nagpur, and my very, very, very close friend Dr. Y.S. Deshpande. I think we have spent hours and hours together discussing on many things, maybe not surgery, but at least other things as far as IMA is concerned. And of course, today's speakers, my other very, very close colleague, whom I think almost every week I interact, Dr. Sanjay Dudhar, always the man, the always who's smiling surgeon. Rarely we find surgeons who are, 24 hours smiling, but he's one of them. And huge experience as far as malignancy is concerned. And let me congratulate Dr. Devtade and Sachin, because I have been, continuously reading of the programs, the number of programs you have been having. And I'm not talking only of the medical education programs, but even, the other programs, cultural programs and whatnot. And it's so nice to see that you all are going beyond what we normally do in a medical organization. So congratulations to the whole team under Dr. Devtade for doing such a fantastic job for the past few months, in spite of there being this COVID problem everywhere. And another aspect I would say is congratulate you is for taking up this subject. See, normally we always hear of just says carcinoma breast and how to treat, how to manage and everything. I was of the era where there were not many cancer surgeons around, and we used to do a lot of breast surgery whenever I was in Sion Hospital. And I still remember it is so easy to just excise something, and we do not think afterwards of what is happening to that lady, psychological impact that it is having, where we do a mutilating surgery. And then, of course, as days passed, and I think as the therapy of say radiation and chemotherapy became better and better day by day, and the surgical aspect went on getting lesser and lesser day by day, to the extent that today we talk about minimum surgery as far as breast is concerned, purely so that you can conserve this breast. And who better than the trio of Dr. Deshpande, Dr. Dr. Dudhat and Dr. Barve madam, and who will go to talk about this subject. So let me congratulate you, because this is one subject which I do not even think much the students are learning in their formative days, and especially seniors like us would definitely like to know, because when the patients come to us, say as their family physicians or as a primary surgeon or anything, the thing that the ladies are most scared of is about losing their breast, not about the malignancy. They're not. Sometimes we find they're not much bothered, and maybe they come very late purely because they're scared that they would lose their breast, and that would be a mutilating surgery. So the topic taken is a fantastic topic which you have taken today. Definitely, I am sure everybody will learn a lot, especially from your esteemed speakers of today. I am going to be around to hear what they are saying, because, as I said, in medicine, we keep on learning right up till the last day of our practice. The day we stop our practice, we stop our learning. So we have to go on learning. So congratulations, Dr. Devtade and Sachin, for doing a great job, and for the whole team for choosing this subject for the medical education subject today. Thank you very much for calling me. As I said, it's always a pleasure to come. Of course, I always enjoy much more when I'm physically present there in Nagpur with all of you. And so it's always a pleasure. And I see my close friend, Dr. Ashish, also around. So great to see all of you all, at least, if not physically, but at least on the screen. And all the best for your program for today. Thank you very much.
Thank you so much, sir, for your wise words. While we are at it, sir, before we begin the academic program, Dr. Shahnaz Chimpanawala, Vice President and Editor of the publication, the e-publication, which we are now having because of the pandemic protocol. Dr. Shahnaz Chimpanawala is here, and she would invite you to release the Intimate. Intimate is the name of our publication, which has now become monthly. It is an extremely vibrant publication that we come out with each month. Over to you, Shahnaz.
Hello, sir. We would like you to release our issue of the month of October. Piyush, please, can you highlight the issue? Sir, we are releasing a e-bulletin every month, and I have got an excellent team with me, Dr. Prachi Mahajan, Manisha Shembrekar, and Mohini Dave who helped me. I request this is on colors. We highlighted the different colors in life, and we wish everyone a colorful life. I request Prachi, who is one of the co-editors, to read out the first page.
Thank you, Shanaz. This month's display is about colors. And what do we have to say about colors appears on the front page, on the first page of our publication. It says, when nature displays her palette of hues, don't just stare in awe. Pick up and fill your life with these hues of letting go of the old and arid, hues of welcoming the vibrant new, hues of farewell to the obliterating melancholic blues, and hues of composing exuberant rhythms anew. Letting go and ushering in be the colors you choose this October. I can assure you that it will be a pleasure reading our issue because it is all full of colors, colors of life, colors of medicine, surgery, and every branch of medicine. Thank you, sir.
Just go through it fast.
Yeah, okay. It always contains IMA news about over the past month. So we cover all the events that have been conducted by IMA. This time we have a celebration and so many activities that were held. We have colorful memories in gynecology and in surgery and in medicine, as I said, in every aspect of medicine. All our distinguished members have contributed to the publication, and it has become extremely vibrant, happy, colorful to celebrate the season. It also includes all the activities, curricular and extracurricular, that we have been following in IMA Nagpur over the years. And also a touch of humor. Thank you, Shanaz, Manisha, Mohini Madam.
Thank you, sir. Thank you, sir.
So we now begin with our academic program, and I now formally welcome our chairman, Y.S. Deshpande, sir.
Madam, movement to chief guest.
Yes, okay, we'll do it now. May I request Dr. Devtare to present a memento, a virtual one, to our chief guest, Dr. Uttare.
Thank you very much, sir, for sparing time with us.
Thank you. Thank you. Only thing I would like to tell Dr. Shehnaz is with the amount of activities that you are doing, Intimate, instead of being a monthly, it has to be a bi-weekly magazine, which will have to come out. Great magazine. I have been reading it in the past also. And it's, I see this time definitely, as what you have said, it is very, very colorful. So congratulations on this great issue that you have brought up.
Thank you, sir. Very appreciated. Thank you.
Thank you, sir. So now moving on to our academic program. As I was formally welcoming Y.S. Deshpande, sir, who is one of the chairpersons for this CME on breast cancer recent advances. Dr. Y.S. Deshpande, sir, we all know him. He is a very senior surgeon and past president of IMA Maharashtra. I am not sure if the other chairman has joined, Dr. Jaiprakash Baras, sir. I don't see him. But I think we should go ahead with our academic program. So over to you, Y.S. sir.
Thank you, Prachi, for all good words you used for me. Dr. Sanjay Devtare, Sachin Ghati, Dr. Sudhir Deshmukh, and Dr. Mahendra Chavan, you have been organizing activities almost every day, and there have been a lot of academic programs throughout, and very nice programs you are organizing. And I am very happy today because two of my friends are here, Shiv Kumar, and as he rightly said that we discuss everything other than surgery. And for a lot of time, I was not knowing that Shiv Kumar is a surgeon, and he was not knowing that I am. But we are very close, and as he rightly said, we always like Dr. Uttare to come to Nagpur, and we feel that he is from Nagpur only, in fact. My another friend, Sanjay. Sanjay is a very close friend of ours in IMA, and he is an oncosurgeon. And I'll tell you one more thing, which Sanjay is doing a great job, great social work he is doing. And he is arranging these book loans for the needy medical students. And that is a wonderful thing he is doing. I have actually seen the books being distributed amongst the poor students of medical colleges. And for last so many years, he is doing this activity and he really enjoys doing that. Now, as far as today's CME is concerned, the topic is extremely interesting, and cancer has always remained a mystery. From our time also, as Dr. Utture has rightly said, that we were doing MRM and removal of the breast those days also. But but there are a lot of changes now. Conservative breast surgery has come into picture, and I'm sure Sanjay would all make us aware about the recent developments, whatever are going on. And as Dr. Utture said, we really feel that what we were doing earlier, whether that was really justifiable. But I would remind you of one article which had appeared in British Journal of Surgery, that Halsted is still alive. If you remember classical radical mastectomy, which we were doing, and now it has been converted into modified radical mastectomy. For all these years, it has still remained a gold standard treatment for malignancy of the breast. But maybe because that time radiotherapy and chemotherapy was not advanced, but now it is so much advanced that now conservative breast surgery with the combination of these two can really produce good results in the patients. So I am sure Sanjay would give justice to the topic he has been given. And Sanjay is a very busy oncosurgeon, but in spite of that, he takes out time for IMA. We are very happy for that. And he's a very busy surgeon. He's attached to Nanoti, I believe, and he's heading the department at Nanoti. And I also appreciate Dr. Utture that in spite of his busy schedule in MMC and his professional commitments, he always finds time for Nagpur. So on behalf of Nagpur, I would definitely place on record my sincere appreciation to Dr. Utture. And with these words, I invite Dr. Sanjay Dudat for this. And breast conservative surgery, a little more thing about that breast is a woman's most precious possession. Nobody wants to lose the breast. And that is the reason why BCS has become very popular, particularly in the urban areas and in sophisticated population wherein they can go for follow-up and go for other modalities of the treatment. So let us listen from Sanjay. Over to Sanjay.
While sir,
I invite Sanjay and Prachi. I think we should start.
Yes, sir. So while sir just starts the screen sharing, I would just like to say we have an excellent array of luminaries from the breast cancer treatment, all modalities here. And while sir starts his presentation, I must just introduce him. You have already introduced him for his social work and association with IMA, sir. But I will say that he is the chief of the Department of Oncosurgery at Nanavati Hospital, which is now Nanavati Max Super Speciality Hospital. He has more than 5,000 major and supramajor oncologic procedures to his credit over the past 30 years. He has more than 25 publications in various national and international journals, various research papers. He has been invited for several guest lectures and orations. And we have seen him as a very active member of IMA as well as being an exemplary oncosurgeon. And sir has already highlighted his work with IMA as chairperson of Medical Education Committee in charge of Aao Gaon Chale and project for training parents of special children. And in addition to that, he is an excellent avid tabla player, which he has been practicing right since childhood. So I welcome Dr. Sanjay Dudhar.
Hello, everybody. Am I audible?
Yes, sir.
Yeah. And my screen is being seen? Slides?
Yes, sir, we can see.
So firstly, thank you very much for, first I would like to thank Dr. Devayani Barve to organizing the CME with you, and the special thanks to our Nagpur IMA. Nagpur IMA is always our friend, and thank you for giving me this opportunity, and with a very good kind words by Dr. Uttare sir as well as Dr. Y.S. Deshpande. I would like to start my talk. Actually speaking, the talk was only breast cancer surgery, in the sense breast conservation, but it's a very small topic. But I thought of covering the all aspects of breast cancer in the nutshell, which will give rise to all recent trends, right from the incidence to the treatment point of view. So you know that overall the cancer incidence is generally increasing globally as well as in India. At the same time, breast cancer is also increasing all over globe, all over Asian countries and India too. Now, I just wanted to highlight some important facts of the breast cancer. If you see WHO statistics, 2.3 million new breast cancer patients every year on an average, out of which 6 lakhs plus die. In India, according to Globocon 2020, last year, we got around 1,78,000 patients, new cases detected. And as you know that this percentage is every year it is increasing. And this is an official cancer registry. Unofficial may be there, we don't know, that may need to add in that. Urban population is more affected. It is a very common cancer of urban India, and it accounts for almost 25 to 32. It's a quite major chunk. As you know that occurrence has been noticed higher in Western countries of this breast cancer. Every minute, one breast cancer is detected all over the globe. Every 13 minutes, one female die of breast cancer. And in India, 1 in 24 women. It was initially 1 in 28, 10 years before. It is now come down to 1 in 24, which likely to develop a breast cancer during lifetime. And it is expected to rise by almost 26% by 2030. Now, our mortality is very high in our country. Why? Because our detection is very late. Higher locally advanced cases, metastatic breast cancer we detect. Almost 60% to 70% cancers are stage 3 and stage 4. And that is why our mortality because of breast cancer is very high. And this changing as trends are very fast all over the world. Now, what is happening with Asian countries as compared to Western countries? You must see this, very important. There is an age shift for breast cancer incidence in Asian countries, and especially in India also, with peak rise in 40s and getting more younger patients from the age 25 to 45 years since last 2 decades. You won't believe, last 16 to almost 20, in 4 years, from age 22 to 39, I operated almost 17 young breast cancer patients. Treated very well. Some people are literal aggressive. Some people were locally advanced, but they are still doing the follow-up. 25 years back, if you look at, see, the percentage of young breast cancer patient in Western countries is pretty low. It is around 2 to 3%. But Asian countries like India is around 15 to 22%. It's quite high than the Western countries. 25 years back, if you look at, when I was in Tata, at that time, almost 70% of the patients were seen above 50 years. Now, look at the today's scenario. Around 48% of the patients are below 50 years. Now, see, the younger breast cancer patients are increasing quite a lot, and this issue needs to be addressed. I attended first young breast cancer conference in Ireland, Dublin, in 2012. And that time that issue was properly addressed, and things were moving that time. And that is why the increased incidence in younger women with aggressive nature of the breast cancer, we know that younger patients have got aggressive tumor biology. They've spread fast, and the overall survival is pretty low. And that has given a challenge for the treatment amongst the oncologists as well as the policymakers. Now, this is how the statistics for a different country, little older one, but just to show how India, we have got a high death rates. Overall patients that time it was 1,44,000. And see the death rates, 70,000 out of 144, almost 50% die in our country. If you look at the United States, 2,32,000, and death rate is dead patients around 43,000. So it is quite high than the Western countries. And why it is? Because their detection in early breast cancer is very high than our Asian countries as to India. You know all these risk factors. I won't go into that. Relative risk with early menarche, late menopause, nulliparity, HRT, alcohol abuse, and everything. Relative risk, which is 2 to 4 fold, it is around first degree relative of breast cancer, age more than 50 for the first childbirth, proliferative breast disease, which is detected by the biopsy, and mammographic breast density, high breast density, very important factor now. And relative risk, which increases the breast cancer by 4-fold, more than 4-fold. It is BRCA1, BRCA2 mutation, lobular carcinoma in situ, atypical hyperplasia in biopsy, radiation exposure before age of 30. I think these are the proper risk where the breast cancer is caused. Coming to hereditary breast cancer, it accounts around 5 to 10% of the cases. And as you know that it has got a BRCA1 and BRCA2 gene testing we normally do. And what we see is BRCA1 is associated with 65 to 81% lifetime breast cancer and 35 to 60% for ovarian cancer. BRCA2 mutation, they are associated with 45 to 85% lifetime risk of breast cancer and 10 to 27% for ovarian cancer. So these mutations are equally important. They are in the breast, they are seen in ovaries. Now they are located in, detected from the cancer pancreas too. And other things are also under evaluation. So, you know Angelina Jolie, who did her prophylactic mastectomy because her family was genetically involved and she was BRCA1 positive. She did a prophylactic mastectomy and later on she underwent ovarectomy also too. And bilateral prophylactic mastectomy with a reconstruction. I think that was the procedure she has undergone. But this type of bold decision, which will come in India, but it will take a little more time. But soon, when you are seeing the younger patients more with genetic predisposition, I'm sure that genetic new patients, young patients are very bold to tell enough, doctor, I knock out my breast, I finished my childbearing because I'm BRCA1 positive. I got a high chance. Now, who are the candidates for genetic counseling? Occurred before 45 years of age, diagnosis before 50, and one of the close relative diagnosed with breast or ovarian cancer. 2 primary breast cancer, at least one diagnosed before age of 50. 2 close relative is breast and ovarian cancer. Personal history of ovarian cancer, and father and brother diagnosed with breast cancer before age of 60. Male breast cancer also been noted, though it is a less percentage, is an aggressive mode, but it is less than 1% up till now. But slowly I'm seeing the little numbers are increasing very slowly in males also at the same time. Now, what is the risk reduction or prevention in such high risk group? See, what has been done is chemoprevention. Trial for tamoxifen for 5 years, which reduced the risk of almost 50% in ER positive patients. But the trial failed because BRCA1 mutation carried ER positive only 20% patients. So trial failed in that. They could not use tamoxifen for other 80% of patients who are ER negative. Then premenopausal oophorectomy, which causes significant reduction in BRCA1, BRCA2 carriers, and it is performed premenopausal age 40 years after childbearing, 35 to 40, and prophylactic mastectomy, which causing risk reduction by 90%, 7% lifetime risk always remains. So this is how the risk reduction procedures are going to be carried out in future as these genetic predisposition factors are going to increase. At present, they are 5 to 10%. We don't know later on how the percentages is going to go up. Coming to screening issues, I'm not going to go for basics. I'm just telling you the important issues in practice. I'm updating you till 2021. We have got a mammography, role of MRI in selected high-risk women, and breast self-examination. Now, breast self-examination, we are doing a lot this thing for that, because even I have a video with BBC Marathi, which first time done in India for breast self-examination in Marathi. It has gone up to 6 lakh people in Maharashtra. Now, this is also equally important as mammography. it is going to help in some or the other way, not exactly as mammography, but it will come near to that slowly, if you teach the breast self-examination properly, which is to be starting at the age of 20. Then coming to mammography, as we know that X-ray of the breast it is. Now the important factors are being asked. What radiation hazards of mammography? Normally, when it is to be started at the age of 40, we all follow American Cancer Society guidelines. There is always a difference of opinion between UK and US. They feel more than 50, they feel more than 40. In India, I would suggest more than 40 because we have got a more younger patients than the Western series. Now, radiation is very low. If you look at what we are seeing, majority is 2D mammography. And the mammography radiation is 0.4 MSV, millisevere. Now, after 2011 onwards, 3D mammography emerged with tomosynthesis. It has come in India in few years back. Now it has got little more radiation, 0.5 MSV. But because of they take little number of sections in that at the same time. And overall radiation risk is around, from that it's around 0.015%. So that answers that there is some sort of risk, but it's very low radiation, very low risk, even if you do every yearly. So, but since we have got a very high percentage between 41 to 60 here, so it has to be continued 1 year. In between, if it is a really low risk group, you can do alternate year mammography, sonomammography, and 1 year sonomammography. So we can do, the only thing you have to identify the low risk group very carefully. Otherwise, miss it on that. And there is also what is called as interval cancers between the mammography. That also to be taken into account. I have seen the patients, doctor, last year the mammography kiya tha, ek saal bhi nahi hua hai. Now I did a mammography, I got a cancer. Now this is how that called as interval cancers of the in between the mammography period. They can appear. They must have been there during that time because of the dense breast, because of some issue, they are not been depicted on the mammography properly. I think that needs to be taken care of. So these questions are normally being asked by the patients. If you do mammography regularly, will I have breast cancer? Very small risk, 0.015%. Now, what is 3D synthesis? Breast tomosynthesis. 3D mammography, it is a 3D technique which is more sensitive and avoids artifacts related to tissue overlap, basically. And it is more useful for the dense breast. Now, since we know that there is little more radiation than the 2D mammography, there is a recent modified technique that synthetic views are available now to create 2D standard via AI machine assistance from the 3D data set, avoiding unnecessary radiation exposure. So they adjust in such a way that your radiation exposure is lesser. It comes to equivalent to 2D mammography. So that is how we need to see the mammography through. And overall reduction in mortality by mammography in all the series, if you look at, it varies between 15 to 32% precisely. So these are the reduction in mortality because of mammography. The reduction detection rates are going to be higher. And sometimes, of course, there are certain false positives also, but it outweighs the accuracy of the mammography on the false positive rate. So mammography is essential, no doubt, for the screening point of view. And what are the American Cancer Society guidelines we normally follow is at the age of 40, we start with 20 to 30 breast self-examination. Now, another question is that when data is there up to 40 to age 72. After 72, we don't have clearly data available. But they said if the patient is fit and patient has got a very high life this thing, so you can still go ahead with the mammography during that, because as it advances, the breast cancer is very high in the elderly age group also at the same time. So there is no age bar for the mammography point of view. That's what the people said. And increased risk, as we know that young breast cancers with a hereditary element, with a genetic predisposition, we normally do MRI in this particular age group. I will come to that. Now, what is breast density? Here and what are the patterns of the markers of the breast cancer risk? Now, what is breast density? Now, as we know that breast is formed of connective tissue, glandular tissue, and fatty tissue. If it is fibro and glandular tissue dense, a lot of tissue than the fatty tissue, then it becomes a dense breast, which is very common in the premenopausal age group. Fatty is more common in the postmenopausal age group. Now, how density is an independent risk factor? Density refers to epithelial and stromal element of the breast. And the greater the amount of epithelial tissue, the greater the chance of breast cancer. And there is a 4-fold increase of the breast cancer in women with a dense breast. It is very difficult to identify in a dense breast the malignancy. Sometimes it missed out. Sometimes it's a false negative also at the same time. How you get false positive? Dense breast, you may get false negative. And in such cases, you can do MRI when you are in doubt. Not all cases. So, mammography is not enough to detect small lesions. The woman with a dense breast, but so consider supplemental test, whole breast ultrasound, automated whole breast ultrasound, contrast enhanced mammography, and digital tomosynthesis, as that what we discussed, which is important. Mammograms of dense breast, sometimes mammography is difficult. So ultrasound might particularly help in younger women, 40 to 49, with a dense breast, with a sensitivity around exceed by 75%. And but it requires a very trained professional. Remember, ultrasonography is observer variant. Who does it? Who interprets? I think that is more important. See, look at this. This is a dense breast. Absolutely. Fibroglandular parenchyma. And this is a fatty breast, which is clearly you can depict the, see, and if you see the next picture, you can see nicely in the fatty breast, this is a classical speculated lesion. And if you see dense breast, it is just overlapping the area. And this is how the lesion, which is being depicted here. But sometimes it may be missed out if the pictures are not clear. So that is how the dense breast things are to be taken into account. These are again the BRADS category, 1, 2, 3, 4, 5, what we normally see. There is again an instrument which came before in 8 to 10 years before, ABBS, that is automated breast volume scanner. Now it not been used much, but yes, we have used it in between. It is increased sensitivity and specificity for detecting some lesions. And it is detailed sonographic volumes of the intricate breast anatomy and pathology. But it is not very commonly used. But yes, we do have this machine. Elastography we are using with the ultrasound technique. And it measures the elasticity of the volumes, which helps in characterize between benign and the malignant lesions. MRI for the screening. What are the specifications? Yes, more sensitive in high risk, genetic predisposition. More likely to pick up duct carcinoma in situ. Mammography cannot pick up duct carcinoma in situ. But no impact on breast cancer mortality, as mammography has. False positive you may have in MRI by more than the mammography, and hence over treatment. MRI cannot be used alone. It is to be always supplemented with your mammography findings. And presently, as a routine screening, MRI has got no data for that. So these are the first few indications for screening. But what are the indications for MRI as a breast cancer point of view? Patient with metastatic node in axilla with negative field mammography and sonography. You can't see the primary in the breast, but they are metastatic nodes, positive. So you can do MRI to detect that. Post-treatment changes after breast conservation surgery. Monitoring the chemotherapy response. Nowadays we use PET than the MRI. Implant complication. If Dr. Devani Bare puts the implant after my surgery, and if I think it is a recurrence, I can do MRI for that. And for the young breast, basically who are dense breast, very difficult to make out, suspicious lesion in that, or younger breast with genetic predisposition, BRCA1, BRCA2 positive. We do MRI starting from age of 30 routinely for every year if they are strong BRCA1 positive. What is the importance of PET CT in breast cancer? Diagnosis for a different operable LABC, that is locally advanced and recurrent breast cancer. You can do good staging. That's most important. Response evaluation after neoadjuvant chemotherapy. Detection of progression and screening. And for screening as well as early detection has got no role. When the PET scan came in the market, I still remember many patients came to me, can I do our PET scan, sir? Monday, it is not possible. You are taking double radiation for that. Don't ever do that mistake. The standard is to diagnose is true-cut biopsy. FNAC, I stopped it 2003 is absolute according to me. It has to be true-cut biopsy, proper core of the tissue, and you can do ERPR, all the receptor study on that. No question about it. And that is how we divide the types of the breast cancer based on the receptors. Is basically luminal A, which is very favorable, ERPR positive, HER2 negative. Luminal B, ERPR positive, HER2 new positive. Then coming to HER2 new overexpressing, ERPR negative, HER2 positive, very aggressive disease, and basal-like triple negative. That is ERPR negative and HER2 also negative. So as we know that the luminal A has got a maximum survival advantage, and luminal B, then basal-like things, triple negative, they are aggressive cancers. Survival rates are very poor. If they come in a vengeance of the recurrence, so it has to be taken, treated in a very properly fashion. Not that we want to remove the breast or we want to do breast conservation. So there are tactics how you should do about it. Suppose you have a little larger tumor and the case is triple negative. First, what we do, we send a genetic testings if the lady is below 50. Number two, if the triple negative, we start with the neoadjuvant chemotherapy. And what we do, we put a marker in that tumor area. Sometimes you get a complete response and you don't know where the tumor is. So we put a marker in that. Then we do surgery, breast conservation, whatever you want to plan, and look at the pathological response. If the histopathological response is complete necrosis, then she doesn't require further management after you are treated. But if there is still residual tumor after your completion of 8 cycles, 10 cycles, whatever is medical oncologist give, and if still the residual disease is there, then she is liable to get some sort of treatment if she is HER2 positive as a trastuzumab or capacitabine in future. So these are the things which are coming up in a bigger way, not only to see the infiltrated duct carcinoma of the biopsy, on the biopsy, always see the trend of ERP, all the receptors. Very important to see the survival of the patient. एक बार पहला गाड़ी चुक गया, आगे का स्टेशन लगता ही नहीं फिर. So it just goes on getting into accidents. So always remember, think carefully before you shoot anything further. Even patient wants surgery first. You have to explain that surgery will not be possible in this particular case. It will not be beneficial for you. Triple negative, little larger tumor, chemotherapy first, even if you can operate. So that is why we need to bifurcate this issue properly. Early breast cancer treatment. If you do, surgery is the backbone for operable breast cancer, then followed by adjuvant chemotherapy, adjuvant radiation if the BCS compulsory, endocrine therapy plus or minus, and adjuvant trastuzumab if they are HER2 positive. So this is how the algorithm goes. Operable breast cancer. As we know that mastectomy, modified radical mastectomy, and breast conservation. They are the other two options. First, we used to do all mastectomy. I still remember when I was in Tata since 1992. So there was a mastectomy. The breast conservation started in front of us that time. Majority things started in above 90s. The sphincter saving surgery, staplers, everything started in front of us. And that is why, but that time also, mastectomy was popular than the breast conservation. Not everybody used to like breast conservation. People used to feel that breast bachaya matlab cancer is there and it will recur back. But now it is so clear that we know that obesity, especially all younger patients, less than 60, we try to do the breast conservation as possible, no question. Modified radical mastectomy, I will not go in detail. Every surgeon knows it here and in Nagpur also. So I won't go into details. The indications, we know that larger tumors, despite there is not much response by chemotherapy, multicentric disease, patient doesn't want breast conservation by any chance, or sometimes patient doesn't want radiation to take, then you can do the mastectomy. So these are standard indications for mastectomy that everybody knows about. Now coming to BCT, it was first proposed in 1930s by Keynes. He published in British Medical Journal 1937, but did not widespread acceptance because cancer was a radical disease that time. So radical excision, that was the basic criteria behind it. So they went for phase 3 trials in US, Europe, consistently demonstrated equal survival in early breast cancer for mastectomy as well as BCT. So these are the breast conservation images which we have done it. So this is a very famous trial of NSABP06. The almost 1800 patient, 1500 patient in R, 4 centimeter was the average size of the tumor upper limit. The 10-year end survival in mastectomy is 76%, BCT is 79%. And in this series, 12 years follow-up endpoint, 62% in mammography overall survival, 65% in BCT. If you look at the local recurrence, mastectomy has got little lesser recurrence than the BCT, but it is not statistically significant at all. And if you look at the overall survival, BCT always exceed better survival than the mastectomy patients, because the addition of radiation therapy giving to the breast and giving to the supraclavicular and axilla area needs lessens the local recurrence in future. and increases the survival. That is how the philosophy and scientificity behind it. So breast conservation as compared to masculinity, slight edge over the survival, no doubt about it. So try your best to do the breast conservation as much as possible in younger patients also. So what is this procedure is wide excision with margin at least 1 centimeter. Now there are issues also for margins. Now whether you want 1 centimeter or 2 centimeter, but at least 1 centimeter tumor-free margins is important. I was in UK for some workshop. One of the big man in UK, he told me, sir, I require only 3 millimeter tumor-free margin in BCT. I don't think we should go that close because their tumors are very small. But our tumors are not that small. So at least 1 centimeter margin, which is absolutely away from the tumor, which is tumor-free histopathological margin, it is very important. No duct carcinoma situ in the margin. Now, whether to do frozen section of margins or not. Ideally, some people Western, some people do frozen section, some people don't do frozen section of margins. I do myself religiously last 20 years, frozen section of margin, at least a gross idea that there is no classical extra duct carcinoma situ or invasion of margins. In India, nobody likes second surgery. It's very difficult to have insurance and there are no much of insurance here. Plus, to have a second surgery, people are not ready. So you can't take that chance. So I normally follow a frozen section. I'm comfortable with that. Now, what are the eligibility criteria? One is good acceptable cosmesis, margin negativity, most important, and capability to deliver. So this is how we normally do wide excision and do an axilla at the same time. Whether you want to do complete axilla or whether you want to do axillary node sampling or sentinel node biopsy along with that. You can do that way. Now, what are the exclusion criteria? Multicentric disease, extensive microcalcification on the mammogram, doubtful compliance for the radiation. You said that a patient may not take radiation. Yes, possible. Extensive DCIs, pregnancy first and second trimester with a precious child, and no satisfactory breast cosmesis, which is relative contraindication. Risk of BCS versus MRM, disease-free survival and overall survival. In all series here, if you look at, these are almost all the same with mastectomy, not any significant, anything which is not significant P value at all. All are almost equal. Same is for local recurrence. There is hardly any great statistical difference between the two in majority of the series, in a good large series. So in a good selected cases, BCT is almost equal to the mastectomy. No question. These are some pictures for breast conservation. This is upper inner quadrant. Pictures taken after 1 year. This is lower inner quadrant. There's all ladies are apparently living very well. This lady is alive for last 12 years. This lady is alive for 15 years. 15 years, 1-5. Now you can have expanded BCT eligibility criteria also. Previously, all central quadrant tumors we used to do mastectomy, but no. The things that again changed. You can do good breast conservation. Remove the whole central quadrant with nipple areola and do a good LD flap and create a nipple area later on. You can create it. Plastic surgeons are super. Dr. Devan is very much here. She's doing good work with us, no doubt about it. It preserves the sensation with intact breast mount with normal peripheral contours, and nipple area constructions can be performed little later. Pregnancy with breast cancer. I have operated 3 pregnancy with breast cancer. One patient I had to do mastectomy, and 2 patients I did a good breast conservation. And this lady came from the Virar with lumpectomized lower quadrant here. In the 7 month, with taking gynecologist in picture proper, with a risk, we did a good breast conservation here. And apparently, patient came out of surgery very well. I told gynecologist, you can do little early if the fetus is completely well developed. God is so great. She delivered 2 to 3 weeks before than her delivery date. Delivered a good baby boy. This is a case of 2007. The boy is now 14-year-old complete. The lady is also fine. She turned out to be triple negative. We gave her post-pregnancy full chemotherapy with radiation therapy. She's absolutely alive for last 14 years. 1-4. If the lesions are non-palpable, here the role of mammography, what we do for early detection comes. If you look at it, it's very difficult to show you the microcal here. Here is the area of microcal. This case I have done it on the day before yesterday, Thursday only. and there was a microcalcification. I'll show you in the another slide. And with mammography, we put hooked wire on the day of surgery and took the patient into the theater. And under the guidance of the wire, we did a wide excision and sent for paraffin section. Normally, we don't do microcalcification frozen section. Becomes very difficult to predict for histopathology in paraffin section after that. So I normally do stent straight away paraffin section rather than frozen. And this is a lump, which is the wire, you can see hooked wire, which has been nicely taken down widely. Now, this is a sonographic wire localization for a very small non-palpable lesion. It was around 7 millimeter, and we did a good wide excision. I had to take little here margins, and the lady is doing so well. It came to infiltrating duct carcinoma with a 7 millimeter size, almost 7 to 8 millimeter size. She did not require chemotherapy because tumor was less than 1 centimeter. Axillary nodes were negative. I did a sentinel node biopsy. She is done with a radiation, and she is on hormone therapy. So these are the certain. Can you see this microcal on this slide? Which nicely taken it out here, very nicely. So breast reconstruction if the mastectomy is done. Now this part I will delete from my side. Dr. Devani will talk before. But even if mastectomy, we can do good reconstruction. And how it is to be good, it is been done. Dr. Barve will explain. Skin or nipple sparing mastectomy also can be done in certain cases. Biological considerations are septic osmosis function, multicentric tumor, widespread DCIS, and large recurrent tumors. Basically, cosmesis is the main issue while doing nipple sparing mastectomy. Is little difficult technique. We need to understand and do it properly at the same time. But we don't do it very frequently. These are some pictures of this tumor on the right side, lobular carcinoma. This lady came from Dubai. We did a wide excision here, and Dr. Devani did a good oncoplasty, and we did an axillary node sampling, which was negative. It was very low grade lobular carcinoma. The lady is on finished radiotherapy, no chemotherapy. We did an oncotype DX for her, but there was no much of information out of it. These are the examples of breast conservation. This was the area of conservation. You can't see even the scar also. And this is the area of axillary clearance. This is a 29-year-old lady operated last year at the peak of COVID, doing very well. This is again a wide excision in that particular area. And Devani did this drawings and everything. She will explain you in her. This is a very nice case, not as a cancer, but we did this one turned out to be a enlarged breast for almost 4 to 5 years for this girl from Aurangabad. And there is a big shadow here. You can see the whole breast is involved with this. So we did an MRI. It turned out to be fibroconnective tissue mass, basically. And these are called as hamartomas. And this is turned out to be one of the largest hematoma in the world. I'm publishing this case, and we removed this, and we did a good reconstruction by Dr. Devani Barve. This is again picture of a phyllodes tumor, how we close it. Coming to locally advanced breast cancer in one slide, these are the pictures what see in T3, T4 stages with N1, N2. Core biopsy and receptor studies are very important. Staging of the PET scan, extremely important. And then you go for neoadjuvant chemotherapy. Initially, the protocol for locally advanced breast cancer was give 3 cycles chemotherapy, operate, and then give. Now the protocol has been changed in last decade. We give all cycles of chemotherapy first till the tumor is necrosed, and then we operate, then we give radiation, and then whatever reconstruction, then we give radiation and then hormone plus or minus. So this is how the tumor is regressed. It's such a large tumor coming up to the skin. The tumor is regression, is almost regressed. So this is how the thing goes. So we all give even 8 cycles we give before surgery. So tumor is, what is our aim? We don't want any residual tumor after the chemotherapy. That is our aim in locally advanced breast cancer also at the same time. These are the certain cases of younger patients wanting to preserve the breast with locally advanced area here with skin involvement. After the chemotherapy, residual scar, excised it here, put in a flap from sidewise, and this is how the cosmesis is. And this is a post-volume replacement follow after some years. So lymphedema. Now there is another thing is sentinel node biopsy. As we know, if you do an axillary clearance completely, level 1, level 2, level 3, there is a good chance of lymphedema in that particular lady. But nowadays, with surgical techniques, everything, it has percentages come down to 6 to 8%. Initially, it was 40% when it was very bad radical clearance. Now, that is why the sentinel node biopsy came in picture. Now, what is the sentinel node? In which the first or sentinel node is the axillary lymph node, which the breast tissue drains, is sampled to determine if the tumor cells have spread beyond the breast or not. So, we normally give methylene blue injection if you don't have a gamma probe, but methylene blue works very well, goes here at the first station. So we put an incision on the axilla level 1 area. We normally see after 15 to 20 minutes of injection of methylene blue, we palpate, massage that area, and we see that node after opening in the axillary node. So 2-3 nodes surrounding that, we send whole thing for a frozen section. And if the frozen section with deeper section says no nodes, we don't go further. But what is prerequisite for this biopsy is the sentinel node biopsy is clinically and radiologically negative axis. I think that is a prerequisite, absolutely. No question, one has to follow that. And this is how, if you see the picture, this is how the node is been blue by the methylene blue. You can use isosulfan blue dye also, and you can use methylene blue along with gamma probe. I will come to that. This is how the gamma probes, we have this now. So we, along with methylene blue, we take this gamma probe to see the sensitivity of the nodes in this particular gamma probe. And we take out these lymph nodes, which are stained by the blue node also. We have taken this trial with the separately with the gamma probe and separately with the methylene blue, and we combined it also at the same time. But we found methylene blue combined with gamma probe has got a more accuracy. So this is how gamma probe is around 12 lakh machine. One can have it. There is no problem in a bigger institution. But interpretation of the pathologist is extremely important. Now, what are the guidelines for sentinel node biopsy? T1, T2 tumors acceptable. T3, T4 tumors not recommended very clearly. Multicentric tumor, yes, acceptable. You can do it with the smaller tumors. Duct carcinoma, inflammatory breast cancer, not recommended. Duct carcinoma in situ with DCIS with mastectomy, acceptable. Without mastectomy, not acceptable, because large DCIS more than 5 centimeters or suspected with proven microinvasion, sentinel node biopsy may not be useful in that particular case. Though older age, yes. Now, male breast cancer, there are good trials been done for sentinel node biopsy. Yes, it can be done with node negative axilla. Pregnancy not recommended. Post prior axillary surgery not recommended. After preoperative systemic therapy, whenever you do neoadjuvant chemotherapy, you are not supposed to do the sentinel node biopsy. Very clear guidelines. And before preoperative systemic therapy, it is acceptable before starting, but not after that. So these are the standard guidelines. Rehab, you know that how to treat lymphedema with all exercises, with pump and everything, which are available with the good physios nowadays. And it has to be trained. And after the mastectomy or after the BCS, if you do when axillary clearance completely, you should have the good training of a lymphedema. That is how the rehabilitation works in all these patients. And this lymphedema is very troublesome. If you don't teach the patient how to live further, how to take care of the hand, how to do reverse massage, how to do the exercises, how to live with this hand, it is very difficult for them to prevent lymphedema. All training should start the next day post-op day 1 surgery. That is most important. How we do counseling for surgery? It is to be next day counseling after breast cancer surgery. First day, what you do is a good counseling to the patient. I think get exercise done from the patient. You become a physiotherapist rather than sending the patient to the physiotherapy department. Now, what is a model histopathology report? What we do the adjuvant treatment is a tumor size in all the 3 dimensions. Tumor type, carcinoma in situ or invasive. Tumor grade, extensive intraductal carcinoma, yes or no. Cut margin status in breast conservation surgery, if the margins are positive or not. Lymphovascular embolization, very important factor. Perineural invasion, relatively. Number of positive nodes, extremely important. High the number of positive nodes, worse is the prognosis. And receptor status, ERPR negativity against positivity, problem. HER2 positive is a problem. Triple negative is a problem. And Ki67 high, all these requires proper chemotherapy as a postoperative period. What are the indications? Just go through premenopausal tumor. Any tumor more than 1 centimeter in premenopausal goes for chemotherapy. Positive nodes, triple negative, ERPR negative, HER2 positive. These are all other factors which will receive a premenopausal chemotherapy. And in postmenopausal, any tumor more than 1 centimeter with positive nodes, or if it is triple negative, ERPR negative, HER2 positivity, you can have chemotherapy for postmenopausal age group also. Unless it is borderline with 2 centimeter tumor with ERPR strongly positive, HER2 negative, Ki67, just barely 8 to 10%. Yes, you can have no chemotherapy in this patient. But if you have borderline, we have to do certain further tests, which I'm come to that. And this is how we put port catheter for all the patients which are requiring extensive chemotherapy like triple negative and everything. Avoid hand as much as possible. And once you put a port, only thing, taking care of the port is very important. Drinking good amount of water and no dehydration and no immobilization, so that thrombosis of port will not occur. I think that is the most dreaded complication I have seen with the port catheter sometimes. I think the ports are very much essential for all the patients. And this is how, whenever there is a borderline issue, whether you give chemotherapy or not, that Dubai patient which I showed you with a lobular carcinoma, low grade, we still did oncotype DICS because she was pre-menopausal 47 years. So even oncotype DICS said there is recurrence score is less than 10%, hardly any preventative chemotherapy. And then we conclude that she will not require chemotherapy. We try to do that oncotype DX. It is very high cost, around 2,80,000 or 3,20,000 nowadays. We have to send this block to US. By working 15 days, they send the report to you. In fact, this patient report came early on the 10th day only. And what we normally predict is low risk, high intermediate risk, and high risk group. The recurrence score prediction and benefit or no benefit of chemotherapy, how they predict into that report. And therefore, you can get a guideline whether you want to add chemotherapy or you don't want to add chemotherapy. Otherwise, chemotherapy will be unnecessary if the benefit is very small. This is how chemotherapy started in CMF, 1970 up to trastuzumab now. Docetaxel, paclitaxel came in the picture when we were in Tata Hospital. Paclitaxel came around 1993 and docetaxel came around 1998. I still remember in 90s, both the important taxanes came. And chemotherapy, now what we do adjuvant is chemotherapy. If HER2 positive, it is added to the targeted therapy, which will add almost 20% of disease-free survival as well as overall survival to the patient. Is chemotherapy with targeted therapy, and in advanced cases, immunotherapy, just to make a mention out of it. Hormone therapy, which we started 1896 with oophorectomy, then 1950 adrenalectomy, and now modern AI since 2004. So we normally give in premenopausal only tamoxifen, no other drug. And postmenopausal, tamoxifen you can give, but more important, more benefit is anastrozole and letrozole, which are the aromatase inhibitors for 5 years. Tamoxifen trials have succeeded for 10 years now. We normally give it for all premenopausal for 10 years till the recurrence comes. And even anastrozole, the recent trial has shown the benefit of 10 years, but you have to take osteoporosis into action. So it can cause osteoporosis. Yes, you have to treat the osteoporotic elements along with the anastrozole and letrozole if you are giving it for 10 years now. So follow-up of the breast cancer treatment is extremely important. The physical examination, we do close follow-up for 2 years, later on 6 monthly, and after 5 years, every yearly. Very important, whenever we do in young breast cancer patient, we normally do ovarian suppression, either medically or surgically, in young breast cancer patients. So they go into menopausal symptoms, decreased libido, vaginal dryness, difficult to talk about it, but significant impact on the quality of life. I think that's why they need not only oncologist counseling, but they need a good psychology and gynecologist counseling also at the same time. I think we need to handle these cases very well. And I have seen this for last 4 years when I did many younger patients, and I used to take time. In fact, sometimes with gynecologists, I sat with the patient and did a very good counseling to both of them, both husband and wife. Extremely important use of moisturizers, lubricants, and partner support. I think this all come in action. Not that Dr. Dudat is doing breast conservation excellent. No, that stories doesn't end here. You have to give quality of life till the end. That is more important. That patient is going to give the best thing out of it. Emotional aspect. Patients are basically absolutely threatened with the whole breast cancer story. They are shattered about the side effects already. Body image is a problem. They are in depression, irritable. All the things are matters, and it has to be handled by the oncologist. I always say, oncologist has to be a very good psychologist. He has to do good counseling. Or if you can't do the impact, get a psychologist or counselor into action and get the things into proper. Treat them as a whole, not the breast or not the breast cancer as such. Lifestyle changes, we always inform that what we do is about good nutrition, healthy lifestyle. Yes, they have to stay mentally and physically healthy. Regular exercise, 20% chance of recurrence later on. And with non-cancer patient also, regular exercise will decrease the chance of cancer by 20%. So all this lifestyle has to be explained to them, to the patient as well as to the relative or who are at the risk in the family also at the same time. So need to be explained to every this. Now, lastly, I would like to put a message which was given to me by one of my very precious patient of 14 years treated, young breast cancer. That time she was 36, BMC teacher, got 7 awards after the cancer treatment up to international level. And now she says, wisdom is to acknowledge the fact that in a life, cancer is not an entire movie, but a short scene in it, a scene where you fight like a warrior, and then only we can ourselves survive. Accept it gracefully and fight against it. Today, the science and developments have emerged with immense capabilities to treat and cure our ailments. And what is then crucial for our any patient is the right time and the right approach in right hands. I think early detection is all the basic key behind it. And that is how we always say, do the awareness properly, get the early detection into high percentage so that our breast cancer mortality will go down. Overall, problem with the patients will go down. At least we can able to have a big disease-free survival in future. That's what we pray for it. And thank you very much. We can still beat the breast cancer. Thank you.
Thank you so much, sir. That was an excellent deliberation of a massive, vast topic in a short time. And I'm very glad that you covered every aspect of breast cancer. Right from the diagnosis to the recent management.
I could have covered only surgical part, but I thought all these points are equally essential while treating the whole thing.
Yes, sir, surely. The other chairperson, Dr. Jaiprakash Baraskar, has also joined, and Dr. Sudhir Deshmukh, President of ASN, and Secretary Dr. Mahendra Chavan are also here. But sir, Dr. Devayani doesn't have too much time. So I think we should begin, if it's okay with everybody, we can begin with her talk and then take the questions and discussions later.
Yeah,
if that is okay.
Okay, that's fine.
Yeah. So I think we move on straight to Dr. Devayani Barve's talk.
Okay, hello everyone. Am I audible?
Yes, you are.
Yeah. Go ahead.
Oh, sir has to stop sharing, then I can share.
Should it?
So while we are getting there, I'll just introduce Dr. Devayani Barve. She has an excellent academic record, a postgraduate in surgery from KEM Hospital, Mumbai, MCH in plastic surgery from Postgraduate Institute of Medical Research, Chandigarh, with excellent performance in all her exams, right from her MBBS days, and she's also taken the USMLE. And she is now associated with various hospitals, well-known hospitals in Mumbai, and also at Max Nanavati Super Speciality Hospital, along where she's working with Dr. Dudhat and Dr. Nagaraj. She has done an aesthetic and breast surgery fellowship in Florida with Dr. Garcia, which is a very privileged fellowship. And she has several associations and international affiliations to her credit. So, Dr. Devayani, over to you.
Thank you, ma'am. I would like to specially thank IMA, Nagpur and Dr. Deshmukh and my friend Sachin, who has organized this whole thing and made it like a grand success. I would also like to thank Utture sir for joining us and, gracing the occasion. So thank you so much, everybody. My topic is mainly structured around creating a beautiful breast. So the newer techniques. Over the years, we all have heard about breast reconstruction and what can be done as whole breast reconstruction. But I have tried to keep my talk specific to reconstructing the odd anomalies which result from breast conservation surgeries or not really the classic reconstruction. A little bit about myself, ma'am has already described, so I don't really need to go into it. One second. Yeah. Okay. Yeah, I always like sharing these pictures because they're very happy memories for me. And this was the core of my plastic surgery training, which was in Miami for 3 years. And I learned a lot from this particular gentleman, Dr. Onilio Garcia, who's kind of like my mentor. All right, so coming to today's topic, like Sir has already talked about a lot of statistics. It's a very significant cancer in Indian females. And now we are seeing a lot of young cancers, even in their early 30s, also some in their 20s also. Some surprising facts, which I also recently found out about breast reconstruction, are that 23% of women, when polls have been taken internationally, they only 23% know about the wide range of reconstruction options which are available to them. Only 22% of them are familiar with what kind of outcomes can be expected from this reconstruction. And only 19% understand that the timing of reconstruction impacts the outcomes and the results. So why reconstruction? Looking at these images gives us a clue as to why reconstruction should be talked about and why it should be offered to all suitable candidates. Imagine living with something like this when you're for the rest of your life, when you're in your 20s or in your early 30s. This is not something which a 20-year-old or a 30-year-old, should be living with or be reminded of every single day. Reconstruction involves recreating the breast size, shape, and appearance. Why should we do it? Because breasts, like any other organ, though it's not a vital organ, it is still an integral part of a woman's body. And more importantly, is an indicator of her femininity for herself, not for anybody else. Breast lost or deformed to cancer in young women, even though it gets cured, can stay as a painful reminder for a lifetime. Every time she wants to dress up, she wants to go out, she wants to feel attractive, she is going to be reminded that, oh, I don't have a breast and I have lost that to a particular disease. And now, especially when we are able to provide safe and long-lasting results, why not? Why resort to using stuffed bras and prostheses which are to be stuck on the body when so many other options are available? Coming to the important point, when should the breast be reconstructed? Now that depends on a lot of factors, some of which Sir has already discussed in great detail. It depends on the type of cancer, what is the histology, how aggressive is it? Depends on the treatment plan, whether radiotherapy is required, not required, whether chemotherapy is going to be given prior to the surgery, after the surgery, what is going to be the plan? And the choice of the patient, whether the patient wants to do it. If so, what option does she want? So a lot of things need to be discussed prior to the surgery. What we can do is, after partial breast removal, that is for early breast cancer, oncoplasty is what is offered. After complete breast removal, that is a complete MRM, when it is done, we can reconstruct the whole breast. And the timing is at the same time as cancer surgery, that is primary breast reconstruction, or after treatment for cancer, that is surgery, chemo, radiation, whatever needs to be done has been done. You wait at least a year in most cases, and then you go in for a secondary reconstruction. Now, coming to today's topic, options for partial reconstruction or oncoplastic reconstruction are divided into two categories. One is volume replacement, when the tissue which is missing, so the part of the breast which has been removed, is replaced by transposing another tissue, similar tissue, from a different location. So that location can be local, that is within the breast, or it can be a distant location, that is from the back or the tummy or somewhere else. And the other option is volume displacement, when breast parenchyma itself is rearranged in a certain way by pre-planning to reconstruct the defect, such as a reduction mammoplasty. And this chart just explains the timing of the repair. So immediate repair is where lumpectomy is done, the repair is performed. After that, radiotherapy is done. This is delayed immediate repair, where lumpectomy is done. You confirm that all the margins are negative, then delayed repair is done, and then radiotherapy is done. So this adds a stage. And delayed repair is where lumpectomy is done, radiation is done, and repair is done after that, maybe a year or so later. So this also adds a stage. Now, immediate repair is when the oncoplastic procedure is performed at the same time as that of the lumpectomy. That is prior to the use of radiation in the same surgery. So this is an example of a patient who had breast cancer detected on one side, and she underwent resection using a Weiss pattern. What is that? I'll come to it. It's a way of skin marking in which you manage to lift the breast up without causing deformity, and at the same time remove the breast cancer through that opening. And a simultaneous procedure was performed on the opposite side for symmetry. So here a cancer has been removed, the breasts have changed their shape, but they look better later. Delayed immediate repair. What does that mean? That means that in some cases, when the facility for assessment of margins intraoperatively is not available or not reliable, a plastic surgeon or a oncoplastic surgeon is not available. When the risk of margins involved by cancer is higher, that is a young age group, aggressive cancer, large tumor, extensive cancer. So these things are indications when you may want to delay a repair. Delay means you do it within 1 to 3 weeks after the lumpectomy, but before starting the radiotherapy. So this timing of repair depends on definitive histopathology report as well as scheduling issues. So confirmation of the final margin status is possible in this case and allows any re-excision. So this is one small advantage. And in case you're doubtful in a certain way, frozen may not be 100%. If you don't want to rely 100% on the frozen, then you can wait for a final margin to come in and then go in for a definitive repair. But these are very rare cases. And a delayed repair. Now, delayed repair is performed after the lumpectomy is done, radiation has been given, and usually 1 year after completing the radiation. It most often involves a local flap, because what happens with radiation is, you can see, even after the reconstruction has been performed later, there are radiation-induced changes in the breast. Now, this can be done for a large breast, large breasts to begin with. It cannot be done for a small breast because small breasts will shrink so much with radiation that there is really not much you can do later in terms of local reconstruction. You will have to bring in a flap from outside. Now, options available for reconstruction. So this, I'm getting a little bit into the technical details of it. The first two, the ones which I have tick marked, this and this, are the ones which are most commonly used for oncoplastic reconstruction. The first one is local tissue rearrangement using pre-planned incisions and breast pedicles. Now, breast pedicle is something which is within the breast, and it is basically the blood supply of the nipple and the areola. So when you're rearranging tissues inside the breasts, you have to plan the incisions well, and you have to make sure that the nipple and the areola is vascularity and sensation is preserved as far as possible. So that requires some understanding of anatomy and pre-planning more than anything else. And the second option, when local tissue rearrangement is inadequate, is bringing in a flap from outside. So most commonly, the workhorse flap for these kind of things is the latissimus, which comes in from the back. Very rare cases in secondary or delayed reconstructions, we may resort to putting in a tissue expander to stretch out part of the skin which has shrunk because of radiation and put in an implant. Again, fat grafting is something which is reserved for secondary reconstructions, but is an excellent modality to fix changes, deformities which may have occurred because of radiation. So I'll come to fat grafting a little later. It's a little interesting development which has happened in the last 10-12 years. So this is a very busy slide, but if I can just break it down a little bit, these are local tissue readjustments and a Weiss pattern kind of incision. Now, this is a Weiss pattern. It's like an anchor. So there is an incision which goes around the areola, one running vertically down the breast, and there is a fold, inframammary fold incision. And these incisions are used to expose the whole breast for the resection to be performed. So this is where the resection has been performed and the breast has been closed. So this lets you rearrange the tissues of the breast itself to create an uplifted breast. Similar things have been done here, where you plan the incision in such a way that the access or the exposure of the tumor is adequate. However, at the same time, you're not disfiguring or giving a scar such that the breast will look deformed. These are just variations of the same periareolar mammoplasty, inferior pedicle mammoplasty. What I mean by pedicle is, in this case, the nipple and the areola is supplied through here. This is the vascularity for it. Lateral mammoplasty means the supply is coming from here. This supply is coming from here. So from superior pedicle. This is the tumor. So these are crucial things of planning which need to be done before the patient is planned for surgery. This is the case which Sir showed. This was a patient who had a very lower lateral defect, but somehow we still managed to, through a J pattern, rearrange the rest of the breast. Now, if you were to ask me if this patient was keen on it, she was just 29 years old. If she's keen on it, then after a year and a half of her treatment having been completed, fat grafting would be an ideal procedure for her. What we do is we just take fat from anywhere in the body, the tummy, the thighs, the arms. We process it, purify it, and we just inject it around the lateral pole, just around here. And that just increases the breast size a little bit. It is natural. It's from her own body, and it's for life. Oncoplastic principles are planned in such a way that the breast is divided into 7 zones. And according to each zone, there are flaps planned. So if the tumor is here, for example, the Weiss pattern kind of excision is planned. This pedicle carries the nipple areola up into the new opening created, and it's closed around that to create a normal shaped breast again. These are just examples of how each zone would be tackled. So there are guidelines. There are some inherent blood supply patterns within the breast, pedicles, which we call, which carry the nipple areola wherever we want to position it, except for zone 4, which involves the nipple areola. So we don't really need to worry about that. We just have to attain closure and reconstruct the nipple areola later if required. So flaps, like I said, this lat flap, latissimus dorsi flap, is the workhorse flap. It's taken from the back. This is with the skin paddle. Sometimes we just take the muscle. We don't need to take the skin at all. And it is swung in front under the armpit through the roof of the axilla. And this, something like this or something like this, is the kind of scar you would get at the end of the procedure. These are just 2 free flaps, which also we use, but more for complete reconstruction of the breast. This is from the lower tummy, free flap, and you can use from the upper thigh, upper buttock, again back. So these are the various options for reconstruction. Latissimus dorsi is a really great option for reconstruction. This is like one of the cases which Sir mentioned. It is the inner quadrant always is a very difficult area to reconstruct because the tissue is always falling away from the body. So there is, if you end up removing a lot of breast in this area, then you're going to get a scooped out appearance, which doesn't look nice at all. And the breast skin tends to go stick to the ribs, which can also become a painful scar in the future. So latissimus dorsi flap is a great option for these defects, where defect is more than 200 grams in an average breast. There are severe size discrepancies, which would have been true in this case, and the tumor location is difficult. This is one of the options which I spoke about. It's an expander implant application. It's when, say, the lateral quadrant of the breast has sunk in because of a prior surgery. And it's caused a scooped out appearance, like one of the deformed pictures I showed you in the beginning. You can always put an eccentric tissue expander, stretch out the skin a little bit, and maybe put in an implant or plan a flap. But these are kind of options which are available to stretch out the skin. Expander, basically we put it in under the muscle of the breast, and then we keep on inflating it with a saline solution such that it stretches the skin over a period of few months, and then we replace it with an implant. This is again an example of a bilateral latissimus dorsi flap done with implants placed. So latissimus dorsi flap, though, is a great workhorse flap for a oncoplastic reconstruction. It may be insufficient for reconstruction of a total breast because the volume is less. The muscle doesn't have enough bulk. So commonly we do combine it with a silicone implant, and it can give great results, as you can see. This is a patient of mine, which I had done in the US. Now, this lady is a little unique in the sense she had a cancer removed from her left side with a LD flap reconstruction done many years back. And but that time she chose not to have the nipple areola done, and she came back with cancer of this side, of the right side, few years down the line. And we again did a similar thing for her here, and she got both the nipple areola reconstructed. So this is it's quite unusual to see it like that, but here it is. Okay, just to touch upon a few things which also we see in practice: correction of a breast conservation surgery deformity. So now here comes the important factor that when a patient comes in with a cancer diagnosis, it is important to involve a oncoplastic or a plastic surgeon at the very beginning. Reason is, then these kind of things may be avoided, or at least the patient is sounded, these options are possible, think over it. If you don't want it, that is fine, that is absolutely fine. But like the statistics I mentioned in the very first place, less than 25% of patients are aware of things, know what to expect, and ask for it. So if we can get those numbers up, it may be possible to give better results. So like Dr. Dudhat was mentioning, we commonly have this, we at least try and follow it at Nanavati Hospital, is that we will, once sir has seen the patient, if he feels that a candidate is suitable for a oncoplastic or a plastic reconstruction, then he will involve me before the surgery. He will not call me right on table, now Devyani, come, let's reconstruct this. No, it can't work like that. You have to know prior, you have to talk to the patient. There are so many nuances of decision making which are in this kind of thing. So the options for this kind of delayed reconstruction are fat grafting. You can excise the whole sunken contracted area and replace it with a flap, or in rare cases you can also plan an expansion. Now this is fat grafting. So fat grafting, what we do is, like I said, we using certain size of cannulas, we aspirate fat from all over the body wherever we can get it. We process it, we purify it, and then using very small cannulas, we again inject it into various areas of the breast to increase the size or correct the deformity. Now this is the case which sir spoke about. I will just highlight the plastic surgery aspects of it. This case really demonstrates the importance of an oncoplastic surgery team approach. Sorry for the spelling error. Preoperative counseling and planning and coordinated surgery. So now this lady, she was young. She was around 25, 26 years old. And she had this big breast she had been carrying around for a long time. She finally came in for surgery. And like sir said, it was diagnosed to be a breast hematoma. Now, the important part of this slide is this, honestly. So this marking and this incision is what helps us give a good result. And this cannot be done if the patient is lying on table. Once the surgeon has, the oncosurgeon has cut however they feel it's appropriate, and then they just call you in for, now do it. It cannot happen like that, because when I tell my patients, I also explain to them that half of my work is before you go under anesthesia, because I will stand with you, I will mark you for about 45 minutes. Not this case, but in general, it takes 30 to 45 minutes to really properly mark a patient, explain things to them. So it's not a instant thing. So that's why a coordinated team approach is important. So we planned a breast lift. This was done to make sure that both her areolas come approximately at the same level. This was done to see that the volume kind of matches. The skin excess, even the areola had to be reduced. The lower one was not possible, but at least the upper side could have been reduced. And post-operatively, if you can see that it has shrunk, it has given a good size match. Even the actual volume of the breast has matched well. And this was not possible just by local tissue rearrangement. So we took in an LD flap. This is the LD flap, which has been brought from behind to the anterior aspect. And with a small skin paddle, which I later did not use. I think I sacrificed it. But this is the importance of a coordinated team approach. So just to summarize, timing of oncoplasty reconstruction is very, very important. Always, always, always mark the incision and pedicle in sitting and standing position before surgery. When I say timing is important, I mean that immediate reconstruction is always the best reconstruction. However, if not possible, it can always be done at a later date. But the patient, it shouldn't be postponed because of misinformation. It can be postponed because of the correct indication. That is acceptable. It is possible to get a near normal looking breast in terms of size and shape in the first stage itself, because options are plenty. Finer refinements such as fat grafting, nipple and areola creation are easily performed under local anesthesia after the whole treatment protocol has been completed. And counseling the patient before surgery is most important. Hence, it is vital to have a joint consultation with an oncosurgeon, a plastic surgeon, the patient, and also a supportive family member, because the patient has so much information going, being given to them, that they need a support with them when they are making these decisions of their own. Thank you. Feel whole again.
Thank you, Dr. Devyani. That was an excellent talk. And the results are there for everyone to see. So it is exactly as you said, creating a beautiful breast post cancer surgery.
Thank you.
Yeah. I hand over to Deshpande sir, Vai sir, and Dr. Baraskar.
Thank you, Devyani, for excellent presentation, excellent exhibition of oncoplastic surgery.
Thank
It
you,
was
sir.
marvelous to listen from you. Can you tell me oncoplastic surgery can be done in LABC patients post chemotherapy?
So it depends on the resection. If the resection is going to be of partial breast, then we can still do it.
Okay.
But it depends on how much. If more than half of the breast is going to be removed, then it's better to probably do a complete removal and then reconstruct.
Okay. Can you tell me this, having a very small breast with breast cancer or large breast with the breast cancer, which is most difficult to reconstruct, or it is difficult for the plastic surgeon to have it?
So both breasts are actually difficult to reconstruct. I'll tell you why. Because in large breast, we find it very difficult to match symmetry, though we can reconstruct it. Then often the other side, normal side, needs some kind of intervention, either a reduction or a lift, which patients are reluctant for. If it's a very small breast, it is possible to reconstruct, but again, the options get limited. If it's very small, it's limited. If it's an average breast, it's the easiest to reconstruct.
Easiest to reconstruct, yeah.
Yes, sir.
Thank you so much, Devyani.
Thank
Dr.
you.
Deshmukh, sir. Deshpande, sir.
Hello, Devyani, congratulations for the wonderful and elaborative talk on this.
Thank you, sir.
My only one comment is, particularly in Nagpur and around, how many patients they go for reconstruction after MRM? Prachi, I think I would like your comment also on that. Because I mean, maybe awareness is less, or I don't know what is the reason, but we see hardly any reconstruction after the MRM. Dr. Jayaprakash would also agree with me.
I do agree with you, sir. But what happens now? Many of our patients, they don't want to have reconstruction, even though we appraise them with that we have the facility of reconstruction, having a new breast all in total. But our patient, they don't want to have it, the reconstruction part.
Exactly. I mean, I think it's a question of attitude and acceptance. They are more of accepting without a breast. And I think the awareness will gradually creep in, because we are seeing younger and younger patients. So I think the awareness is going to come in the near future. But what we are able to offer right now is excellent.
So much is the difference between Nagpur and Mumbai patients?
Yeah, there is difference, sir. Definitely there is difference.
Because there are so many cases which Devyani has shown us, and even Sanjay during the presentation about the breast conservative surgery and all that.
In Nagpur, patients are reluctant for BCT also. So reconstruction is a step further, but they are not even willing for BCT.
Cases are
they're increasing, but I mean, still,
it is
comparable with
it is increasing. But what Madam says, that's right. These patients are not very positive for even BCT. They want to get rid of the breast and the disease as well. They feel that if the breast is removed, they'll get rid of the disease. Exactly. That is the thing.
Right.
Sanjay, just one comment for your presentation. It was a very comprehensive talk, and all of us we were mesmerized by your talk. You talked about Angelina Jolie and US awareness about the breast cancer and all that, wherein Angelina Jolie went for a prophylactic mastectomy, both the breast.
Yes.
Whereas here we hardly find any cases in a very early stage.
Yeah.
Many times from the rural areas, we see most of the cases in stage 4, wherein the ulcerative mass is there, which many times gets fungated and all that. And because relatives, they cannot tolerate the smell at home, they bring the patient to forcibly treat the patient. So, I mean, such is the difference that when the breast mass is not, when genetically it is detected, then people are getting treated there. And here the awareness is still lacking. I mean, we need to, because early diagnosis and prompt treatment is the hallmark for the success of breast treatment, breast cancer treatment, as you rightly said. So I think we need to work on that, maybe through IMA, through ASN and other organizations taking the social organizations along with us. And I think we need to work quite a lot on that.
Since I am the chairperson for cancer awareness for Maharashtra, so I am planning for next year in a bigger way. In the Maharashtra, we can do good awareness. We make a systematic workup all over Maharashtra, taking all of you into confidence, and we'll do it accordingly. I think that is much needed because we have got early detection is 12.3%, sir. Rest all locally advanced. It is that low.
That's true. Over to Prachi.
Okay. Sir, before we move on to the next lecture by Dr. Nagaraj, I would request Dr. Sanjay Devtare to present key mementos to Dr. Dudhat and to Dr. Devyani Barve.
Thank you so much. Thank you so much, sir.
And thank you.
Thank you so much.
So with permission of the chair, I would request Dr. Nagaraj to take over for his talk. We all know that radiation oncology is an extremely integral part of management of breast cancer. And we have a luminary in the field of radiation oncology here. Dr. Nagaraj graduated from Karnataka Dharwad University and did his post-graduation from AIIMS Delhi, joined Tata Memorial Hospital, and he is an extremely innovative person, and he has innovated the Department of Radiation Oncology right from what it was in the past to the most modern equipment that he has today. He is a visionary, a voracious reader, an excellent orator, as we shall soon see, a researcher at heart, and an inspiration. He has more than 100 publications in national and international journals. He has also came up with the Society for Cancer Research and Communication, which I think is extremely important. And this society has published 5 books and one, including one on medical ethics. So he has been a founder of the Journal of Cancer Research and Therapeutics. He is chief editor of this journal right now. And he also believes that if you have the right to live with dignity, then you have the right to die with dignity. And today he is the president of the Society for the Right to Die with Dignity in India. Extremely important. He has affiliations to various national and international societies. And he has also been awarded with Citation and Lifetime Award by the Indian Medical Association in 2013. Over to you, Nagaraj.
Thank you. Thank you so much. And good evening. Thank you, IMA Nagpur. It was a privilege to hear Dr. Sanjay Dudhat and Devyani talking about surgical management and the reconstruction, which is exceedingly important. Moving on, this is what I used to call, it's one of my old slides. Mercifully, we don't see that anymore because even when the MRM is done, we have people like Dr. Devyani who will reconstruct that. I used to call it a Halcyon curse. Both Halcyon and son perpetuated this. Initially, I thought maybe they are misogynist, but maybe they, as at the very beginning, somebody said they didn't have the benefit of radiation therapy. So this is not what we should never see ever in the 21st century. Well, be it Nagpur or Mumbai, this is what we should look at. And again, it's one of my old slides where in BCT has been done. You can see the pigmentation on the left side. So, well, most of us always present the best case scenario. This is one of that. It's very rarely.
May I interrupt
Sorry?
you? We are not able to see the slides, sir.
No, but I already shared it.
It's not visible, sir.
Now what do I do?
So
Have
you'll
you
have to
clicked on
select
chess?
you'll have to select the window which is showing your slides.
Yes, I did that. This is exactly what I did when I.
Please try sharing again.
Yeah, that's what I'm doing. Now, can you see it?
Not yet, sir.
Not yet. Okay, I'll try to do them some other way. Oh, you can still not share it, is it?
We can see you now, sir. We can't see your screen.
That's right.
But do you need any help with that?
Yeah, how do I do that? Your officer.
So do you have your presentation open in the background?
No.
Maybe you can do a video call with sir and help him out.
Oh, okay.
I rehearsed this and let me try and do this. Now, can you see this? Hello.
No, sir.
Please take control of his screen with any desk or team viewer.
So how do I do it?
How?
Yes, sir.
Take control of his monitor with any desk or team viewer.
Yeah, 1 minute. I am on a Zoom. Which one should I have? So to share this.
Dr. Hulkar, do you have AnyDesk?
Sorry, that?
No,
Do
he
you
doesn't
have
have
a software called AnyDesk?
No, he doesn't have any desk right now. He'll have to download it. 1 second, please.
Doc video. Can you see it now?
No.
Where's the document?
I showed you the document.
No, it's in Google Drive.
No, it's on.
It's on the main screen.
Yeah.
What's the name?
Yes. No, just go back. Okay.
I can do one thing. Share screen.
Yeah, share my screen. That's it. No. I think I have to ते breast ते PP आहे ना ते share होत नाही.
Yeah.
Huh?
Can you
Yes,
see it
you are
now?
on now, sir. Yes, yes.
Okay. All right. Sorry. Yeah, I'm sorry for this mess. I'm
No
such a
problem, sir.
all right. There we are. So I'll let you start all over again. As I said, this is an accident. Of course, probably they didn't have an access to radiotherapy then, and inevitably they did end up with a very costly outcomes like this. This is one of the best scenario treated a couple of decades back. You can see pigmentation on the right side. This is what you should aspire for, be it in just about anywhere. And this is perhaps feasible because the techniques of radiation oncology or radiotherapy have increased. They're much better than before. And the awareness that it's not just enough to increase survival, but the idea of self-image and idea of plastic reconstruction that's feasible, possible, that you heard, it must be considered at the very beginning. And as all of them have emphasized, you must put your surgical scars at the right place. What is radiation to that? What I would probably do is just explain a bit of radiation therapy, how it works, and so on and so forth, and try and make you understand various jargon, which is very often used in the context of radiotherapy. Well, radiation can be given alone, not so much in breast cancer. It can be pre and post, just generally post in breast cancer. Radiation with chemotherapy should be considered, can be considered sometimes, though even in breast cancer. And radiation with hypothermia, not many people are aware of this. Some excellent studies from Duke's has shown a level 1 evidence for use of hypothermia especially in recurrent chest wall, right? And hypothermia, we had this program running with us. We have just stopped hypothermia after practicing it for nearly 2 decades. It could be following breast conservation. It could be following mastectomy, or radiotherapy can be just to achieve a certain level of palliation. Well, you have heard enough of debate on what it is, MRM and BCT. It's almost settled that we need, as far as possible, a conserved breast. But there are situations wherein you can't really get into BCT, and you've got to still go in for mastectomy, but not as bad as the Halstead mastectomy, but of course the modified one. And cosmos is as much a crucial ingredient of our objectives. But why radiotherapy? Be it mastectomy, be it radiotherapy, the objective has to be to reduce local recurrence and increase the survival. So it's again because we have, as Sanjay said, since our screening and self-breast examination awareness, more and more early cancers are being picked up, and we have BCTs. So as I said a while ago, radiotherapy is an integral part of the treatment, be it a conservation or be it after the mastectomy. So how do we go about it? It could be whole breast. With standard fractionation could be for 6 to 7 weeks. There's something which has started very recently, which is called hypofractionation, which extends for 3 to 4 weeks. We'll talk about it a little later. There's something called a partial breast, which gets over in 1 week. You can have a brachytherapy following that. That is, put in needles of radioactive needles inside, or it can also have intraoperative. That means much like you would probably have plastic surgeon up front. You can also probably put in treat the tumor cavity or a lump cavity with a certain radiation, and that's called intraoperative radiotherapy. And all of them do have merit and advantages and disadvantages, and fairly good level of evidence. So we have whole breast, partial breast, we intraoperative, external beam radiation, and we have in-tissue radiation. And these are some of the indications for radiotherapy. both after the mastectomy and after BCT. I will not go into the details. It suffices to say you need radiotherapy. There are, however, certain contraindications wherein you should not be considering. Well, I mean, if it is a multicentric disease, that you clear margins, etc., you know, where the BCT is not possible, you go ahead. But the very, very important contraindications are something like scleroderma, SLE, autoimmune disorders, and these are very important, or metastasis, wherein you really wouldn't like to, you know, consider radiotherapy. And why is that? Some of these patients with scleroderma or SLE or have very, very sensitive skins, or they can be, their soft tissue is very sensitive to radiation, as a result of which you will end up with a lot of toxicity. So you should not really, and that's an absolute contraindication. So you know, someone has to really see and how, you know, upfront, you cannot really go in for a BCT if there are absolute contraindications. So indications for radiotherapy mastectomy has remained almost the same: more than 5 centimeters, chest wall involvement, axillary node metastasis, skin ulceration, edema, fixation to chest wall. These are all for the following. Mastectomy, if one has all these, one or many of these, or multiple variables, multiple prognostic factors are involved or are positive, you need radiotherapy postoperatively to the chest wall. Why breast? Why should we radiate? This is just to give some more support, saying that it does reduce local recurrence, and perhaps at the end of 20 years, there is also a survival benefit. And it not only reduces local recurrence in the chest wall, but also this is a very stark table, wherein it shows that RT and no RT. If you don't have RT, these are all randomized trials, and you see an exceedingly high level of recurrence, right? So right from 27 to 40%. So it's wise, it's better, hence, to treat all these patients post-operatively, be it after BCT or mastectomy, because we know that, and there is an evidence that they do reduce the local recurrence. We have situations like DCIS, and people have, for some reason, have tried their very best to you know, eliminate radiotherapy as far wherever they could. Sorry. Yeah, so the DCIS is one such situation, but even in DCIS, when you see that if you're not gone in for a mastectomy, or if you have, you know, lumpectomy itself, or even sometimes when you've done a mastectomy, it's imperative that you do plan a postoperative radiotherapy of some kind. RT after, why, you know, excision, again, it reduces recurrences by 45%. I'm saying it again and again to emphasize that low recurrence really goes down. Survival by and large increases. So there are enough studies to show you that post-operative therapy makes a lot of difference, and we should not repeat the same mistake of trying to eliminate radiotherapy, except in a very highly selected cases. We can discuss that later. So every treatment has a side effect. What are the side effects of radiotherapy? It can be fibrosis, edema, and lymphedema, especially if the very bad axillary dissection has been done. There can be soft tissue necrosis, rift fractures, pneumonitis, pericarditis, and telangiectasia. Now, pneumonitis is a bit of a problem these days because a lot of people get quite a few cycles of chemotherapy. And this has been my experience that in the last few years, I have seen a couple of pneumonitis. So what in an early case, and hence to avoid some of these side effects and improve the cost process, and this knowledge that most of the recurrences are within 1 or 2 centimeters of the primary tumor, people looked at the possibility of treating the partial breast and not the whole breast like we generally do. And this is called accelerated partial breast radiation. Again, in medicine, I think if you choose the patients right, your outcomes are better. And there are recommendations as to how you should do it. Age more than 50 years, is infiltrating that carcinoma, T1, T2 less than 3, N0, and preferably I add ER/PR positive or HER2 negative. That's my indication. So what are the do is I think I showed that in the first slide, earlier slides, wherein we treat the partially as very small volume of breast very quickly within a week, so that it's not only very, very convenient of patients, but eventual cosmetic outcome is much, much better perhaps than it would be if we treat the whole breast. I spoke about the intraoperative radiotherapy. That's not, the idea was never new, but however, there has been a very, very large trial to see whether the intraoperative, in a very highly selected cases, we can do an intraoperative radiotherapy very effectively, and perhaps we can do that. This is one of the studies, and this is how it was randomized. And after the BCT in a very early lesions, we can do intraoperative radiotherapy. There are various ways of doing it. There's what we see interstitial on the left side, mammocyte in the center. Target is another way of doing it. And then also you can do an external beam radiotherapy, like which we generally routinely have. But this is all much, that's for the APBI. And these are some of the intraoperative ways of treating. What is the advantage? Immediately after the surgery, you mop it up with radiotherapy and the patient doesn't have to come at all. So technique radiotherapy has evolved. It was evolved tremendously. This is how I started. The machine to the left is a telecobalt machine. Remember that it did a lot of good. I mean, it's still good, but the linear accelerator, which this is the one which I have with image guided radiation, etc., is the latest in the line of technologies, which assures a very fast treatment. And to this particular machine, the delivery rate is very high, especially when I do an IMRT, as a result of which breathing is not such a problem, so breath holding may not be so critical in this particular machine. So what is that I'm saying? The technology has evolved from cobalt to linear accelerator, and there's something called intensity modulated radiotherapy. We'll talk about it later, and also something called protons. And you can see proton at the very bottom of it. We have one proton in Chennai, and one more is coming down. What would be the advantage of protons? Probably, if you look at the left side, there you see half the chest wall getting painted, or more than that. These are all various techniques using photons, but when you come to the protons, you see a very smart distribution or a hotspot just along the chest wall. It's work in progress. I would not recommend protons at this time to patients with breast cancers, especially because there's so much of uncertainty about movement, breathing, and dosimetry. This is one of my earliest patients of interstitial post-operative. It was not done intraoperatively, but immediately after the surgery. And this is called brachytherapy. So we have external beam radiotherapy with photons, then we have intraoperative radiotherapy, and we have interstitial radiotherapy. These are all the various techniques that we have. Right. So once we understand these various techniques, we understand the differences between them, and then contextualize in the in the context of the treatment and treatment outcomes and the side effects. Now, this is one of the patients which has undergone three-dimensional conformal radiotherapy. What does it mean? You try to confirm the 100% of radiotherapy with the target, which in this case has been bilateral breast. And then we have treated this simultaneously because this patient came with the breast tumor on the both, and BCT was done. They're eligible for BCT, and we try to. It's a very simple way of doing it, but you can see that some part of the lung is included, and luckily, mercifully, most of the heart is outside the treatment volume. But however, during the breathing cycle, it's possible that some portion of the heart might get in. This technique is called intensity modulated radiotherapy, and this is again a bilateral, like before. This is done to show you the comparison. This is an exceedingly complicated way of planning the treatment. There can be what we call as a volumetric modulation, or there could be multiple beams. So all those lines that you see there are multiple beams, and there's a computer which keeps calculating that. I keep telling that it's like Rangoli. You can, or it's based on the face recognition software that you use on your Facebook. All right, the basic software. It's very complex. So what do we do again here? We try to deliver a very highly homogeneous dose or a conformal dose to the target volume. As compared to the earlier technique, this technique is so much better, but some amount of heart gets a very low dose radiation, but it is better than the usual 3D CRT on occasions, and they're very, and especially in patients with mastectomy, I prefer IMRT because the homogeneity of dose delivery is very, very high, and that's very important. And this is how we use ultrasound to get tumor bed and so on, so for the boost. This is again just to show you how we started with conventional with 3D treatment. You saw IMRT distributions on the right side is proton, and they all look very elegant, sexy. But that right this point of time, I don't think proton should be routinely recommended at all. This is chest validation. Again, few more samples of our own patients. Now, I was talking to you about pneumonitis. Yeah, pneumonitis is one of the challenging side effects, not immediate, but the late side effects. And in the middle CT scan, you see a certain a cotton wool appearance, and that is due to pneumonitis. And you can see that, you can see the red line and the green line above and below. It suggests that area did get certain amount of radiation. Most of this pneumonitis is grade 1, grade 2, which means it's asymptomatic. They won't really bother the patients. But when they see this fluffy changes in the CT scan or the X-ray chest, everybody goes into a frenzy. Yeah, but I have seen very occasionally symptomatic pneumonitis, and there are some newer recommendations to how we can reduce the pneumonitis. Well, most of the late sequelae, like edema, fibrous mastocyte pneumonitis, etc., are proportional to the dose or dose per fraction, not just the dose. So herein comes the idea of conventional fractionation, hyperfractionation. This is one of my old slide of pneumonitis, but not for breast. Okay, so now to understand how the fraction size is relevant for immediate and delayed side effects, we need to understand how radiation works. Radiation works by damaging the DNA, and some of the cells get repaired, and some of the cells don't get repaired. Those which don't get repaired die, and some of this, or they undergo mutations, but if they die, they're eliminated. So we have a repairable component and we have irreparable component. That's very important for us to understand the relevance of fraction size. Eric Hall made a very, very seminal contribution in understanding the relevance of fraction size. I think that's just I'm going to tell you very briefly and quickly. You can see in these graphs, these are the very important graphs. We call it as a linear quadratic model, and you can see alpha and beta written to the right in the right side. Okay, it only says that alpha component is of the DNA component, which is so damaged that it cannot be repaired, and beta otherwise. What is it? And another concept that we need to understand when we're talking of various fractionation is therapeutic index. If the blue line is for the control and the red line is for the normal tissue damage. So we should stretch the blue to the left and the red to the right. So if we make that wide, then we have a very safe outcome, or we can escalate the dose as well. And herein again comes the relevance of fractions. It is a very complicated, not very complicated, or some certain mathematical modeling, which came much after Eric Hall. This is called linear quadratic equation, where D is the dose per fraction. Okay, here. This is very important. So we have something called alpha and beta. Why I'm emphasizing all this is all fraction schedules that have emerged is based on this. Alpha is about lethal injury, beta is of non-lethal injuries. So what do we do with all this information? So there's something called alpha beta ratio, and that is preferred when we are treating in prostate and breast cancer, because when we do that, there's not much of a difference between acutely responding tissues or late responding tissues and the tumor. So we can very safely perhaps give a larger dose in a shorter time. And that's what we have been doing these days. And these are the various studies for hyperfractionation, which shows an effective reduction or equivalent reduction in local recurrence. There was a time when I started practice, or even 3 to 4 years, still 3 to 4 years. It was pretty standard for us to give 5 to 6 weeks of radiation with 5 weeks and then a boost and so on and so forth, and a little less for mastectomy patients. And now this particular fractionation has become very fashionable, and 40 in 3 weeks and a boost plus or minus, and it seems to be working very well. There is a technique called simultaneous integrated boost. You can see it in blue. What we do sometimes is give a very high dose to this particular area and a very small dose to the rest of the breast, and that's how we achieve hypofractionated radiotherapy. And there's a research to show how we do that. Pneumonitis is a big problem. Generally we have this is another super patients treated on supine posture. Some of the machines now built for breast radiation itself have this provision to have the patient treated in a prone, and as you can see, hardly any lung gets included. Hardly any lung gets included either in the heart, either to the heart or the lung. So the incidence of both pneumonitis or pericarditis in something like this goes down. Left side is 3D, right side is IMRT. So look at the IMRT distribution is so uniform. The entire breast gets radiation the way we want. As I showed you some other technique, we can do a simultaneous integrated boost as well. Okay. And this is recently when the COVID appeared. When the COVID appeared, not just this hyperfractionation became very popular. And this again, there's something called extreme or a very fast hypofractionated radiotherapy. You can see it in the left blue box. This is something like 26 grain 5 fractions. Very fashionable. I don't recommend it. And there are some institutions which have adopted this. This is called fast forward in breast cancer. What they are trying to say is, whether you treat by 40 grain 15 fractions, 27 in 5, or 26 in 5. They seem to be equivalent. These are just a 3 or 4 year data. We don't know the late side effects, especially the impact on cosmesis. I am very wary, not just because I'm old, but I'm very wary of a very high fraction size when it comes to late sequel, and especially if the people are obese, I don't really like to go in for a extreme hyperfractionation, and if I get the dose distribution right in these patients, I don't mind. I do still go in for the usual hyperfractionation, that is 40 and 15 and a boost or something like that. So that is about why and how we treat external beam radiotherapy, and how the technology has changed, how protons is work in progress, how the fractionation has a very sound radiobiological basis. We understand what is alpha beta and so on and so forth. There are many mathematical models. They are much more robust than the prediction models. And on the basis of that, we have a fair bit of level 1 evidence that hyperfractionation works without compromising in cost basis. As I said at the very beginning, it's not just a survival, but to offer dignity to the woman all through life by offering a sense of jury, as Devyani would put it, is very important. That's what that's how we contextualized technique and technology, and I'll be more than happy to answer the questions. But that's not it. As I said, that we have palliative radiotherapy as well. It could be in the bone, it could be in the brain. This is something like a solitary brain metastases like this from breast cancer can undergo either whole brain radiotherapy or a stereotactic radiotherapy routinely. Well, this I'll skip because this was when the new techniques come, especially in America, US, or the market forces just come into force. So it's very, very important for us to not to be driven by the market forces, understand why something is being done, why is it really good as compared to before, and is it applicable to in our own context? Do we have the technology? Do we have the people to do all of that? So don't go by these billboards. I still remember even the CyberKnife came, we had all the CyberKnife advertisements. So don't go by these names, CyberKnives, protons, and tomotherapies, and all of that. They're machines. Well, the name of the machines. What is very important for us to understand is how radiotherapy works. Yes, it does. Where are the various techniques, and IMRT and 3D CRT is the one which we need to look at. Hypofractionation is the reason it works, and radiotherapy is also very, very useful in palliation if not when we cannot cure. And there are very, very few cases, highly selected cases, wherein we can really skip radiation, but otherwise we should never even try to do that. These are some of the conclusions which is on the which I summed up, and thank you so much. These are the people who helped me to put in all the slides, and they were not here, so I had to ask my son to help me. Sorry for the mess, and thank you so much for giving me this opportunity to be here with as a part of the IMA with my dear friends, Dr. Sanjay Dudat and Dr. Barve, Devyani Barve. I've seen some of her cases with excellent cosmoses, and thank you again, and I'll be free to answer any questions.
Thank you so much, sir. That was a very comprehensive talk. Chairpersons. Vice sir. Dr. Baraskar.
Yes, Prachi.
Yes, sir.
No, it was such a comprehensive talk. I don't think there are any questions for that. Do you have any questions in the chat box, Prachi?
No, sir. Some comments about all the talks being very good. There are no questions there.
Radiotherapy is an integral part of the treatment for cancer, and all these things like conservative breast surgery and all that is possible only because of radiotherapy. Because every patient of BCS, we need to go send the patient for radiotherapy, and we are getting more and more modern equipments and modernization as far as radiotherapy is concerned. And Dr. Nagraj sir has very rightly said that this is a very integral part, and this is very important as a part of the treatment. So thank you so much, Dr. Nagraj, for your wonderful presentation. And over to Prachi.
Thank you.
Can I request Dr. Devtare to present a memento to Dr. Nagraj sir? Thank you, sir.
Thank you so much. Thank you for the invitation, and thank you for the lovely moment. Thank you so much.
Thank you. I think we've come to the end of this session. I request Secretary of IMA, Dr. Sachin Ghati, to propose a vote of thanks.
Thank you very much. Thank you, Prachi ma'am. So after a really good talk of all the three speakers about the breast conservation surgeries and breast cancer management, I thank you all on behalf of IMA Nagpur in association with Association of Surgeon Nagpur branch. I thank you our chief guest Dr. Utture sir, he is MMC chairperson. Our first speaker Dr. Sanjay Dudat sir, our own IMA man, my friend Dr. Devyani Barve, a renowned plastic surgeon, upcoming, and she has really great future. And Dr. Nagaraj sir, thank you very much for your excellent deliberation on this topic. And this month is a breast cancer awareness month, so it's a very relevant CME also. And also thanks to our esteemed chairperson, Dr. Y.S. Deshpande sir. Everyone knows him. Dr. Baraskar sir, a well-known oncosurgeon from the city of Nagpur. And I am not I'm very thankful to our MOC and moderator, Dr. Prachi ma'am. She has conducted this CME really well. Thank you very much. Piyush, please present e-memento. Please display the e-memento of Dr. Prachi madam, Prachi Mahajan madam.
Thank you so much.
Thank you, ma'am. And thank you Prachi madam is our very active member. I am an Nagpur member. So thank you very much. Also thankful to our audience as well as our digital partner DigiShield, Deepen and Piyush, for supporting this CME. Thank you very much, and good night. I will not take much time, so it's already late.